MRI. B. (117). E. Routine breast screening. Ultrasound is not a screening tool. Character. Chapter 3 Test Paper 2. Questions. Time. 3 hours. 1. An intracardiac mass was incidentally detected during echocardiography in a patient undergoing preoperative assessment. Chest X-ray was nonspecific, showing an enlarged heart. Which one of the following statements regarding primary benign cardiac tumors is false? A. Cardiac fibromas are homogeneously low on T2W MRI. B. Cardiac lipomas are high on T1W MRI. C. Cardiac rhabdomyomas are associated with tuberous sclerosis. D. Cardiac fibroelastomas usually arise from the pericardium. E. Cardiac myxomas show heterogeneous signal on MRI. 2. A 40-year-old man under Chapter 4 Test Paper 2. Answers. 1d. Cardiac fibroelastomas usually arise from the pericardium. Most lipomas appear to be subepicardial, expanding into the pericardial space. They typically have high signal on T1. T1 weighted images and low signal on fat-suppressed images. Fibroelastomas occur on cardiac valves, making them the most common neoplasm of the valves. They are hypointense mobile masses situated away from the free edge of the valves. Fibroma is a neoplasm primarily of infants and children. Fibromas are homogeneously hypointense on T2 weighted images and show variable enhancement. Rhabdomyomas are the most common benign cardiac tumor of childhood associated with tuberous sclerosis. They originate within the myocardium, typically in the ventricles, may be multiple, and are high on T2 weighted images. The majority of myxomas manifest in adulthood between the 4th and 7th decades. A minority will constitute part of an autosomal dominant syndrome known as Carney complex, characterized by myxomas, hyperpigmented skin lesions, and extracardiac tumors, such as pituitary adenomas, breast fibroadenomas, and melanotic schwannomas. The classic triad of symptoms attributed to myxomas include cardiac obstructive symptoms related to obstruction to blood flow, embolic events, and constitutional symptoms such as fever, malaise, and weight loss. At MR imaging, the vast majority of myxomas demonstrate heterogeneous signal intensity. The main differential diagnoses for myxoma include atrial thrombus or papillary fibroelastoma. Myxomas are more likely to arise anteriorly from the interatrial septum, whereas thrombus is more likely located posteriorly in the left atrium. In addition, myxomas enhance with gadolinium contrast material, whereas thrombi, in most cases, do not. Sparrow PJ, ETAL MR imaging of cardiac tumors. Radiographics. Undergoes a CT scan of the abdomen for recurrent abdominal pain. The pre-contrast scan showed bilateral renal calculi. A post-contrast scan showed several pancreatic lesions, measuring between 1 and 2 centimeters. What is the likely unifying diagnosis? A. Men-IB, Men2AC, insulinoma D, glucagonoma E, NF1. Radiographics. 2005. 2005, 25, 512 55 76. 2a. Men-I multiple endocrine neoplasia type 1 is also known as Wermer syndrome. Inheritance is autosomal dominant with high penetrance. The male-to-female ratio is 1:1. Organ involvement includes parathyroid hyperplasia, 97%, pancreatic islet cell tumor, 30% 80%, anterior pituitary gland tumor, 15% 50%, and adrenocortical hyperplasia, 33% 40%. NF1. 3. A 45-year-old woman presents with a rapidly enlarging mildly painful breast mass over a period of few months. An urgent ultrasound is performed. The ultrasound shows that the mass measures 7 centimeters, filling up almost the entire breast with fluid-filled clefts in the tumor. What is the diagnosis? A. Inflammatory carcinoma. B. Cystosarcoma phylloides. C. Complex breast cyst. D. Invasive lobular carcinoma. E. Breast lymphoma. Three. B. Cystosarcoma phylloides. Phylloides tumor, PT, is a rare breast fibroepithelial neoplasm. It is now generally accepted that PTS can be classified as benign, borderline or malignant. Mammography and ultrasound are notorious for their inability to distinguish the benign or malignant histologic nature of PTS. On US, they can be indistinguishable from fibroadenoma. They appear as an inhomogeneous, solid-appearing mass. A solid mass containing single or multiple, round or cleft-like cystic spaces, and demonstrating posterior acoustic enhancement strongly suggests a diagnosis of PTS. Solid components of the tumor show vascularity on Doppler. On MRI, well-defined margins with a round or lobulated shape, and a septate inner structure have been described as characteristic morphologic signs. They are usually low on T1, weighted images and vary from low to very high signal on T2, weighted images. Some have described a silt-like pattern on MRIs of benign PTS. These appear as hyperintense slit-like fluid-filled spaces on T2, weighted images, with a low signal. After enhancement. Solid areas of the tumor show enhancement with contrast. 10H ETAL imaging findings in phyllodes tumors of the breast. Ur J. Radial. 2012, 81, 1E6029. 4. C. Are typically cortical rather than subcortical-based lesions. Osteoid osteomas are benign and aggressive bone tumors that are more common in men and usually present clinically in patients less than 30 years of age. They are most commonly based within the cortex, although they can also occur in any other area of the bone. When larger than 2 centimeters, they are regarded as osteoblastomas. 4. Osteoid osteomas, A, are aggressive bone lesions with malignant potential. B, are referred to as osteoblastomas when larger than 3 cm center. Are typically cortical rather than subcortical-based lesions. D, typically require surgical curettage and resection. E, are more common in women. 5. A 67 osteoblastomas. Radiofrequency ablation is now a common and viable treatment for these lesions throughout the UK. Dannert W., Radiology Review Manual, 67-year-old known alcoholic man with acute onset neurological symptoms has been referred for an urgent CT brain to exclude hemorrhage. CT shows an isodense subdural on the right, but the history of trauma was 24 hours earlier with no previous history of head. 61. Injury or fall. All of the following are causes of isodense subdural hematoma on CT following head trauma, except A. A 2-week-old head injury with subdural hemorrhage. B. Acute subdural hematoma, in a patient with HB 7.5G/DLC. Chronic hematoma, in a patient with coagulopathy. D. Patient with an associated arachnoid tear. E. Patient with leptomeningeal metastasis. 6th ed. Philadelphia, PA, Lippincott, Williams and Wilkins. (2007:136). 5. E. Patient with leptomeningeal metastasis. CT attenuation of blood in the subdural space remains denser than brain for 1 week, and is less dense after 3 weeks. There is an interim period of 2 weeks when it is isodense to brain tissue. In addition to variation in appearance over time, subdural hemorrhage may have a variable appearance in a setting of systemic disease like anemia and coagulopathy. An acute SDH can appear isodense in the following settings: anemia with a hemoglobin concentration of 10 g/dl, admixture of CSF in the subdural space caused by an associated tear to the arachnoid layer, and disseminated intravascular coagulation. If there is chronic CSF leakage of venous blood, for example, if the patient has coagulopathy or is on anticoagulants/antiplatelet agents, chronic hematoma may look isodense rather than hypodense. Meningeal metastasis may appear as hyperdensity on gyri and mimic subarachnoid hemorrhage. Adam A. et al. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York. Metastasis. 6. A child presents with intermittent abdominal pain, vomiting, and a right upper quadrant mass. On clinical examination, blood is noted on rectal examination. A clinical diagnosis of intussusception is made. Where is the most common site of intussusception in this population group? A. Ilio. York, Churchill Livingstone, 2008:1344. Zassler N.D., et al. Brain Injury Medicine, 2nd edition, Principles and Practice. 3. Neuroimaging and Neurodiagnostic Testing. New York, Demos Medical Publishing, 2013:200. 6. B. Ileocolic intussusception is one of the most common causes of acute abdomen in infancy. Intussusception occurs when a portion of the digestive tract becomes telescoped into the adjacent bowel segment. This condition usually occurs in children between 6 months and 2 years of age. In this age group, intussusception is idiopathic in almost all cases. The vast majority of childhood cases of intussusception are ileocolic. U.S. is highly accurate in the diagnosis of intussusception with a sensitivity of 98%, 100%, and a specificity of 88%, 100%. U.S. is also good at demonstrating alternative pathology. Hence, enema could be reserved for therapeutic purposes when U.S. is available. Del Pozo G. et al. Intussusception in children, current concepts in diagnosis and enema reduction. Radiographics. 1999, 19, 229. Ilio B, ileocolic C, ileocolic D, colic E, jejunoileal. 7. A 29-year-old woman with fever, malaise, fatigue, intermittent pain and numbness in both hands and feet, and normal chest radiograph is referred for MRI thorax. MRI shows wall thickening of the origin of the right subclavian artery and both carotid arteries. What is the diagnosis? A. Moyamoya disease. B. Takayasu arteritis. C. Churg-Strauss disease. D. Pan E. Wegener's granulomatosis. 7. B. Takayasu arteritis. Takayasu arteritis is a form of granulomatous vasculitis affecting large and medium-sized arteries, characterized by ocular disturbances and weak pulses in the upper extremities, pulseless disease. It is associated with fibrous thickening of the aortic arch with narrowing of the origins of the great vessels at the arch. Takayasu arteritis can be limited to the descending thoracic and abdominal aorta. It is seen in young and middle-aged patients, especially Asian and women. The diagnosis is confirmed by a characteristic arteriographic pattern of irregular vessel walls, stenosis, post-stenotic dilatation, aneurysm formation, occlusion and evidence of increased collateral circulation. Polyarteritis nodosa is a fibrinoid necrotizing vasculitis that mainly involves small and medium-sized arteries of the muscles. Multiple aneurysm formation is a characteristic finding. The kidney is most commonly involved, followed by the GI tract, liver, spleen and pancreas. Positive ANCA titers, usually PANCA type, are found in variable percentages of patients. Wegener's granulomatosis is a distinct clinicopathologic entity characterized by granulomatous vasculitis of the upper and lower respiratory tract together with glomerulonephritis. Churg-Strauss syndrome is characterized by granulomatous vasculitis of multiple organ systems, particularly the lung, and involves both arteries and veins as well as pulmonary and systemic vessels. Moyamoya disease is a progressive vasculopathy leading to stenosis of the main intracranial arteries. Characteristic angiographic features of the disease include stenosis, or occlusion of the arteries of the circle of Willis, as well as the development of collateral vasculature that produces a typical angiographic image called clouds of smoke or puff of cigarette smoke. HAHK, ETAL radiologic features of vasculitis involving the gastrointestinal tract. Radiographics. 2020, 37. A slimly built 60-year-old woman presents with anorexia, diarrhea, and weight loss. Barium meal shows multiple filling defects in the stomach with thickened gastric rugae. Colonoscopy shows multiple colonic polyps. The top differential is A. Peutz-Jeghers syndrome. B. Familial adenomatous polyposis. C. Cronkite-Canada syndrome. D. Cowden syndrome, E. Tickett syndrome. 9. A middle-aged woman presents to the breast clinic with a few weeks history of 77994. Taraso E. ETAL Moya Moya disease, diagnostic imaging. Paul J. Radiol. 2011, 76, 173-9. 8c. Cronkite Canada syndrome. Cronkite Canada syndrome occurs in older patients with an average age of 60 with no familial predisposition. The histologic appearance of the GI polyps resembles that of juvenile polyps, and they are characteristically distributed throughout the stomach. They are commonly small, sessile and characterized by cystic dilatation of the glands and inflammation of the lamina propria. Patients commonly present with abdominal pain, protein-losing diarrhea, anorexia, and weight loss. Dystrophic nail changes and alopecia usually appear after the onset of GI symptoms. Cho G, ETAL Peutz-Jeghers syndrome, and the Harmadomatus polyposis syndromes, radiologic pathologic correlation. Radiograph. History of vague breast pain and lumpiness. On further direct questioning, she reveals a history of trauma to the breast a few months ago. Mammogram shows a well-defined circular mass with central translucency and eggshell calcification. What is the most likely diagnosis? Diagnosis. A. Cyst. Radiographics. 1997, 17:78591. 9. D. Fat necrosis. Fat necrosis is a frequently encountered cause of benign calcification, particularly when there is a history of trauma. It appears well circumscribed with translucent areas in the center, homogeneous fat density of the oil cyst. Occasionally, it shows curvilinear or eggshell calcification in the wall. On US, it appears as a hypoechoic or anechoic mass with ill or well-defined margins, with or without acoustic shadowing or as a complex cyst. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott. Cystosarcoma phylloides B, complex breast cyst C, invasive lobular carcinoma D, fat necrosis E, fibroadenoma. 10. A 60-year-old patient is admitted for progressive thoracic back pain with a low-grade fever, which has been going on for several weeks. Routine chest radiograph reveals no abnormality. An MRI of the spine reveals minimal intervertebral disc space reduction at T4/5 with hyperintensity of the disc. There is adjacent vertebral end plate edema and irregularity. A well-defined end. Chapter 3. Test Paper 2, Questions. 62. Predominantly high T2W signal collection is noted, extending beneath the anterior longitudinal ligament and cranially to reach the level of T2. What is the most likely diagnosis? A. Williams and Wilkins, 2011:577-8. 10. D. Pot disease infection usually begins in the anterior part of the vertebral body adjacent to the end plate. Subsequent demineralization of the end plate results in loss of definition of its dense margins on conventional radiographs. These end plate changes allow the spread of infection to the adjacent intervertebral disc, resulting in a classic pattern of involvement of more than one vertebral body together with the intervening discs. It also allows spread into the paraspinal tissues, resulting in the formation of a paravertebral abscess. However, if there is anterior subligamentous. Chapter 4. Test Paper 2, Answers. 85. Involvement of the spine, infection can extend both superiorly and inferiorly, with sparing of the intervertebral discs. A normal chest radiograph is present in up to 50% of cases. In the later stages of disease, there is often vertebral collapse with a gibbous deformity. Tuberculosis rarely affects the posterior vertebral elements, including the pedicles, in contrast to metastatic disease. Anterior scalloping seen with subligamentous spread of infection can also be seen with paravertebral lymphadenopathy, secondary to metastases or lymphoma. In differentiating tuberculosis from pyogenic infection, the clinical picture is as important as the radiologic features, with insidious onset of symptoms, a normal erythrocyte sedimentation rate, relevant respiratory symptoms and slow disease progression favoring a diagnosis of tuberculosis. Radiologic features that favor this diagnosis include involvement of one or more segments, a delay in destruction of the intervertebral discs, a large, calcified paravertebral mass, and the absence of sclerosis. Sarcoidosis can produce multifocal lesions of vertebrae and discs, along with paraspinal masses that appear identical to tuberculosis. Burrell J. ETAL tuberculosis, a radiologic review. Radiographics. 2007, 27, 512-55-7. A. Pyogenic discitis B. Insufficiency fracture with ongoing collapse, complicated by chronic vertebral osteomyelitis C. Degenerative disc disease with modic type 2 and plate changes D. Pot disease E. Vertebral lymphoma. 11. A 16-year-old boy with progressive extrapyramidal symptoms, dementia and positive family history was sent for an MRI brain by his neurologist. MRI showed bilaterally symmetric hyperintense signal changes in the anterior medial globus pallidus with surrounding hypointensity in the globus pallidus on T2W images, commonly described as eye of the tiger sign. Caudate was normal and no other areas of signal change was demonstrated. What is the diagnosis? A. Wilson disease B. Huntington disease C. Mellas D. Haller-Warden-Spatz disease E. Cadasel. 73. 11. D. Haller-Warden-Spatz disease the eye of the Tiger sign represents marked low signal intensity of the globus pallidi on T2, weighted MRI, surrounding a central, small hyperintense area. The sign is seen in what was once known as Haller-Warden's HS syndrome, but is now called neurodegeneration with brain iron accumulation, NBIA, or pantothenate kinase 2, PANC2, associated neurodegeneration. The low signal is a result of excessive iron accumulation, and the central high signal is attributed to gliosis, increased water content, and neuronal loss with disintegration. Iron levels in blood and CSF are normal. HS is a neurodegenerative disorder associated with extrapyramidal dysfunction and dementia. The sign can also be seen in other extrapyramidal Parkinsonian disorders, such as cortical basal ganglionic degeneration, Steele-Richardson-Olszewski syndrome, and early-onset levodopa-responsive Parkinsonism. High signal in the basal ganglia, thalamus, and midbrain is seen in Wilson disease. Caudate is atrophic in Huntington disease. Cadasal shows extensive white matter signal change and Mellis shows multiple focal white matter signal changes. Chauhan GB, Schrofa millimeter 20 classic signs in neuroradiology. Neuroradiology, a pictorial essay. Indian J. Radial Imaging. 2009, 19. Cadasal. 12. A 2-year-old boy presents with a large abdominal mass, and there is suspicion of an underlying neuroblastoma. Which feature would be supportive of this diagnosis with the highest confidence? A. Calcification is uncommon. B. Well circumscribed. C. Displaces major vessels rather than encasing them. D. Encases major vessels but does not invade them. E. Claw of renal tissue extends partially around the mass. 13. A 73. 19. 2 135 45. 12. D. Encases major vessels but does not invade them. Neuroblastoma, NBL, is the most common extracranial tumor in childhood and commonly presents as an abdominal mass. Abdominal and pelvic tumors are usually large and heterogeneous, and approximately 80%-90% demonstrate calcification on CT scans. Low attenuation areas of necrosis or hemorrhage are frequently noted at CT, vascular encasement and compression of the renal vessels, splenic vein, inferior vena cava, aorta, celiac artery and superior mesenteric artery may occur, and vascular invasion is rare. Regional invasion of the psoas and paraspinal musculature may occur, and invasion of the neural foramen into the epidural space is also frequent. These are better evaluated at MR imaging, as is regional organ invasion. Metastatic disease of the liver and lung are readily evaluated with CT. They are typically heterogeneous, variably enhancing and of relatively low signal intensity on T1 weighted images, and high signal intensity on T2 weighted images. Wilms tumor demonstrates a claw of normal renal tissue around the tumor. In contrast to neuroblastoma, vessels are displaced rather than encased and vascular invasion occurs in approximately 5%-10% of cases. Dumba M, ETAL neuroblastoma and nephroblastoma, an overview and comparison. Cancer imaging. 2014, 14, Supple 1015. Lonergan GJ, ETAL neuroblastoma, ganglioneuroblastomoma, and ganglioneuroma, radiologic pathologic correlation. Radiographics. 2000. Correlation. 73-year-old woman with previous history of myocardial infarction was referred for a chest radiograph by her GP to exclude chest infection. No infective focus was identified but a focal bulge was noticed in the left heart border, with curvilinear calcification along the edge. What is the diagnosis? A. Myocardial calcification. B. Right atrial calcification. C. Mitral annulus calcification. D. Calcified vegetations. 13. Left ventricular aneurysm calcification. A cardiac false aneurysm is defined as a rupture of the myocardium that is contained by pericardial adhesion. It usually represents a rare complication of myocardial infarction, but it may also occur after cardiac surgery, chest trauma, and endocarditis. True left ventricular aneurysms are discrete, dyskinetic areas of the left ventricular wall with a broad neck. Unlike a true aneurysm, which contains some myocardial elements in its wall, false aneurysm are composed of organized hematoma and pericardium only. Both demonstrate focal bulge to the cardiac contour and can calcify. Marked delayed enhancement of the pericardium on dynamic enhanced MRI may help in differentiating a false aneurysm from a true one. Conan E. ETA. AL true versus false left ventricular aneurysm, differentiation with Mr. Imaging initial experience. Radiology. 2000. Vegetations E, left ventricular aneurysm calcification. 14. A 70-year-old man presents with rectal bleeding. Flexible sigmoidoscopy shows a circumferential tumor in the upper third of the anal canal. An MRI performed for staging shows locoregional lymphadenopathy. The lymph node group most likely to be involved is A, superficial inguinal. B, common iliac. C, pudendal. D. 2005, 236, 165-70. 14. A. Superficial inguinal metastatic spread to regional lymph nodes represents the most common mode of tumor spread from cancer of the anal canal and margin. Nodal metastasis is more likely in cases of larger tumor size, or a poorly differentiated anal tumor. Metastasis most commonly occurs to the perirectal nodes, with inguinal nodal spread being the second most common location of nodal metastasis. McMahon C.J., ETAL lymphatic metastases from pelvic tumors, anatomic classification, characterization, and staging. Radiology. 2000. D. External iliac E. Paraortic. 15. A fit and healthy 25-year-old woman presents to the breast clinic with a small mobile non-tender breast lump that she noticed incidentally. An ultrasound is deemed as the first line. Chapter 3. Test Paper 2, Questions. 63. Investigation. It reveals an extremely well-defined homogeneous, hypoechoic oval mass with posterior acoustic shadowing. What is the most likely diagnosis? A. Cystosarcoma phylloides. B. Fibroadenoma. C. Complex breast cyst. D. Invasive lobular carcinoma. E. Fat necrosis. 16. A 35-year-old. 2010, 254. 131-46. 15. B. Fibroadenoma. Fibroadenomas are the most common cause of benign solid mass in the breast. On US, they appear round or oval, wider than tall, hypoechoic, well-defined and mostly homogeneous and show a hump and dip sign, small focal bulge to the contour with a contagious small sulcus, a thin echogenic pseudocapsule and rarely either posterior acoustic enhancement, 17% 25%, or posterior acoustic shadow, 9% 11%. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:578-9. 16. D. Quadrilateral space syndrome. The anatomy of the suprascapular. 35-year-old weightlifter presents to the orthopedic clinic with pain in the right shoulder. An initial radiograph is normal and no abnormality is identified on US. An MRI is suggested for further evaluation. It reveals increased T2W signal changes with fatty atrophy of the teres minor muscle. What is the likely diagnosis? A. Parsonage-Turner syndrome. B. Spinoglenoid notch paralabral cyst. C. Duchenne's muscular dystrophy. D. Quadrilateral space syndrome. E. Acute rotator cuff tear. Suprascapular nerve renders it particularly susceptible to compression at the suprascapular notch and spinoglenoid notch. The pattern of muscle denervation provides information about the duration of entrapment and can identify the site of neurologic compromise. Acute denervation presents as hyperintensity of the supraspinatus and infraspinatus, or of the infraspinatus muscle alone on fluid-sensitive sequences. Chronic compression is shown as a reduction in muscle bulk and fatty infiltration of the involved muscles. Involvement of both the supra and infraspinatus muscles reflects proximal compression at the suprascapular notch, whereas isolated infraspinatus denervation suggests compression at the spinoglenoid notch. Quadrilateral space syndrome is a rare condition referring to an isolated compressive neuropathy of the axillary nerve. It generally results in isolated atrophy of the teres minor and, less commonly, of the deltoid, which appears as a reduction in muscle bulk and fatty infiltration with chronic compression. Parsonage-Turner syndrome is an uncommon, self-limiting disorder characterized by sudden onset of non-traumatic shoulder pain associated with progressive weakness of the shoulder girdle musculature. MRI is the technique of choice in patients with shoulder pain and weakness. It is sensitive for the detection of signal abnormalities in the shoulder girdle musculature related to denervation injury. MRI is also useful in excluding intrinsic shoulder abnormalities that can produce symptoms similar to Parsonage-Turner syndrome, such as rotator cuff tears, impingement syndrome, and labral tears. Chapter 4. None of the findings or history would be compatible with an acute rotator cuff tear or Duchenne's muscular dystrophy. Yanni S., Toms A.P., Mr. Patterns of denervation around the shoulder. AJR, AMJ Rentgenal. Tear. 17. A 45-year-old male patient with low back pain, rectal bleeding, and fecal incontinence is investigated with CT and MRI. CT shows an enhancing soft tissue mass replacing the sacrum with areas of amorphous calcifications. On MRI, the lesion shows low to intermediate signal on T1W and high signal on T2W images. What is your diagnosis? A. Sacral meningocele. B. Sacral chordoma. C. Central dural ectasia. D. Rhabdomyosarcoma. E. Sacrococcygeal teratoma. Rentgenal. 2010, 195:2. 17. B. Sacral chordoma. A chordoma is a tumor that derives from notochordal remnants. At imaging, it typically manifests as a large, destructive sacral mass with secondary soft tissue extension. Radiographs may show sacral osteolysis with an associated soft tissue mass and calcifications. CT shows bone destruction with an associated lobulated midline soft tissue mass. Areas of low attenuation within the mass reflect the myxoid properties, high water content of the tissue. Areas of punctate calcification often are noted. At MR imaging, the most striking feature is the high signal intensity seen on T2 weighted images. High T2 signal intensity is a non-specific feature, however, the combination of high T2 signal intensity and a lobulated sacral mass that contains areas of hemorrhage and calcification is strongly suggestive of a chordoma. Chordomas tend to show hypointense or isointense signal. Relative to that in muscle on T1, weighted images and contrast-enhanced images show a modest degree of heterogeneous enhancement in the soft tissue components of the tumor. Areas of intrinsic T1 signal hyperintensity typically represent areas of hemorrhage or mucinous material. The tumor may cross the sacroiliac joint. Farsad K. E. ETAL sacral chordoma. Radiographics. 2009. Teratoma. 18. A 3-year-old girl presents with a cough, temperature and hyperinflated left lower zone, elevating the left hilum. What is the likeliest diagnosis? A. Congenital lobar emphysema. B. Viral pneumonia. C. Cystic fibrosis. D. Pulmonary sequestration. E. Inhaled foreign body. 2009, 29, 515 25 30. 18. E. Inhaled foreign body. Most inhaled foreign bodies are organic and may not be visible on chest X-ray. It is recognized that chest X-ray can be normal with inhaled foreign bodies and clinical suspicion needs to be high. The most common findings are unilateral, distal obstructive emphysema, followed by normal X-ray. Lower lobes are most commonly involved. Long-standing unrecognized foreign body may present with recurrent or non-resolving consolidation or unexplained segmental collapse. Passily D. ETAL foreign body inhalation in children, an update. Acta otorinolaryngol ITAL 2010, 30, 127-32. Body. 19. A 72-year-old man presents to the vascular surgeon with abdominal pain for months after endovascular repair of an abdominal aortic aneurysm. An emergency dual-phase contrast-enhanced CT is performed. The unenhanced images reveal high-density material interposed between the stent and the wall of the aorta. There is further enhancement of this high-density area on arterial phase images. The graft and the attachments look intact. What is the most likely diagnosis? A. Type I 32. 19. B. Type 2 endoleak. In a type I endoleak, there is poor apposition between one of the attachment sites of a stent graft and the native aortic or iliac artery wall, and blood leaks through this defect into the aneurysm sac. A type I endoleak can be seen immediately after stent graft deployment. On CT, dense contrast collection is usually seen centrally within the sac, and is often continuous with one of the attachment sites. Type 2 endoleaks are the most common. They occur when there is retrograde flow of blood into the aneurysm sac via an excluded aortic branch, most commonly IMA, or a lumbar artery. Many type 2 endoleaks close spontaneously over time. CT shows peripheral or central location of acute hemorrhage. Leakage of blood through the body of a stent graft results in a type 3 endoleak. Type 3 endoleaks manifest as collections of hemorrhage or contrast material centrally within the aneurysm sac, usually distant from the attachment sites or native vessels. Opacification of the aneurysm sac immediately after placement of a stent graft without a discernible source of leakage is designated a type 4 endoleak. A type V endoleak, or endotension, is characterized by continued growth of an excluded aneurysm sac without direct radiologic evidence of a leak. Basher MR, ETAL endoleaks after endovascular abdominal aortic. I endoleak B, type 2 endoleak C, type 3 endoleak D, type 4 endoleak E, type V endoleak. 20. A 76-year-old woman with 6 months history of progressive weight loss and altered bowel habits is referred for a CT scan of the abdomen and pelvis. The examination shows several hypoattenuating lesions on segments 2 and 3 of the liver that are highly suspicious for malignancy. Blood biochemistry with 2 more markers shows a normal AFP and CA19-9 but raised CEA. LFTs are minimally deranged. The case is discussed at MDT. Chapter 3. Test Paper 2, Questions. 64. What is the most likely differential diagnosis and further management plan out of the options given? A. Primary hepatocellular carcinoma liver biopsy. B. Hepatic adenoma liver resection. C. Probable lung cancer. CT chest. D. Metastatic renal carcinoma renal biopsy. E. Metastasis from colonic adenocarcinoma colonoscopy. E. Metastasis from colonic adenocarcinoma colonoscopy. Associated malignancy. 2 more marker primary other malignancies. Oncofetal antigens AFP primary HCC teratoblastomas of the ovaries and testes CEA colorectal carcinoma various carcinomas. Hormones beta HCG choriocarcinoma testicular cancers, non-seminotomous, trophoblastic tumors calcitonin medullary carcinoma cancer of the thyroid, liver cancer, renal cancer metanephrines pheochromocytoma neuroblastoma, ganglioneromas chromogranin A pheochromocytoma, neuroblastoma men, small cell lung cancer, carcinoid tumors IGF, 1 pituitary cancer insulinoma. Glycoproteins CA15 to 3 breast cancer various carcinomas, CA19 to 9 pancreatic and gastric carcinomas various carcinomas. CA72 to 4 gastric carcinoma various carcinomas, CA125 125 ovarian carcinoma various carcinomas. Isoenzymes PSA prostate cancer NSE small cell lung carcinoma neuroblastoma, kidney tumors. Cellular components/products LASAP various carcinomas, leukemia, lymphoma, Hodgkin's disease SCCA squamous cell carcinoma of the uterus, cervix, lung, and head and neck tag 72 gastric carcinoma colorectal, lung, pancreatic and ovarian cancers immunoglobulins multiple myeloma gammopathies. AFP, alpha-fetoprotein, beta-HCG, beta-human chorionic gonadotropin, CA, carbohydrate antigen, CEA, carcinoembryonic antigen, HCC. HCC, hepatocellular carcinoma, LASAP, lipid-associated sialic acid P, men, multiple endocrine neoplasia, NSE. NSE, neuron-specific enolase, PSA, prostate-specific antigen, SCCA, squamous cell carcinoma antigen. Sharma S., Tumor Markers in Clinical Practice, General Principles and Guidelines. Indian J. Med Pediatra Onco. 2009, 31. Colonoscopy. 21. A late middle-aged woman undergoes an MRI breast with contrast to investigate a clinically palpable nodularity. Fat-suppressed 3D images show a 3 cm well-defined abnormality with peripheral enhancement. Which of the following statements regarding enhancement pattern is incorrect? A. Rim enhancement is a nonspecific finding. B. Fat content is a sign of benignity. C. Homogeneous enhancement is a sign of benignity. D. Centripetal spread of contrast is more common in carcinomas. E. Homogeneous high T2 signal suggests malignancy. 22. Which statement is not associated with transient patellar dislocation? (118). 21. E. Homogeneous high T2 signal suggests malignancy. Smooth margins, characterized by well-defined and sharply demarcated borders, are the feature with the highest benign lesion predictive value. Round and oval shapes have also been found to be predictive of benignity. Homogeneous enhancement is highly suggestive of benign nature. Fat content. Chapter 4. Test Paper 2, Answers. 89. Is specific to benign lesions, such as hamartoma, fibroadenoma, intramammary lymph nodes or fat necrosis. In the case of fat necrosis, even if the lesion appears irregular in both shape and margin, with rim enhancement, the key to diagnosis is a fat internal signal on unenhanced sequences without fat suppression. Strong hypersignal on non-fat suppressed T2, weighted sequences is classically considered to be a clear sign of fibroadenoma, but but it is nonspecific, and is seen in mucinous carcinomas, invasive ductal carcinomas, metaplastic carcinomas and intracystic papillary carcinomas, although it does not have a homogeneously high T2 signal as fibroadenoma. Although rim enhancement is regarded as suggestive of malignancy, a regular enhanced rim, which may be thick, may be seen around cysts, seroma, both of which are high T2 fluid signal, and fat necrosis, high T1 signal. In relation to enhancement kinematics, a centrifugal contrast uptake pattern may help in diagnosing a fibroadenoma, whereas a centripetal spread of contrast is more common in carcinomas. Millet I, ETAL pearls and pitfalls in breast MRI. BRJ Radiol. 2012, 85, 1011 197 207. 22. Dislocation. A. The medial patellar reticulum frequently demonstrates high T2W signal changes. B. A tibial tuberosity to trochlear groove distance of 1.5 centimeters. C. Trochlear dysplasia is a predisposing condition. D. There is an increase in the ratio of the patellar tendon to the patellar length. E. Bone contusions of the anterolateral aspect of the lateral femoral condyle. B. A tibial tuberosity to trochlear groove distance of 1.5 centimeters. Transient patellar dislocation is the dislocation of the patella laterally and subsequent relocation. Trochlear dysplasia, patella alta, increase in the ratio of the patella tendon to the patella length, and an increase in the tibial tuberosity trochlear groove, TTTG, distance are associated factors. TTTG greater than 20 mm is abnormal and 15-20 mm is considered borderline change. TTTG less than 15 mm is within normal limits. Contusional marrow edema is often seen in the medial patellar facet and the lateral femoral condyle. The medial patellar reticulum and / or medial patellofemoral ligament, MPFL, may be torn or show a pattern of strain injury. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:69. 23. B. Condyle. 23. A 45-year-old patient with chronically progressive low back pain is referred for an MRI scan. Sagittal T1W and T2W MRI lumbar spine show dehydration of the L4/5 disc, with low signal to the disc on T2. High signal is noted in the adjacent end plates of the L4 modic type 2 and L4 and L5 vertebra on both the T1W and T2W sequences. There is no cortical destruction. How would you report the finding? A. Modic type I end plate change. B. Modic type 2 end plate change. C. Anderson lesion. D. Modic type 3 end plate change. E. Discitis. Plate change. Modic describe 3 types of reactive changes in the cancellous bone adjacent to the vertebral end plates. Type I change is low on T1 and high on T2, representing edema secondary to acute fibrovascular tissue invasion. Type 2 change represents fatty replacement of red marrow, bright on T1 and T2. This leads to bony sclerosis, low on T1 and T2. Occasionally the end plates become irregular and the degenerative process progresses to a destructive discovertebral lesion, simulating infective discitis. The key differentiation is signal of the disc, which is high in discitis and low in degeneration. Anderson lesions refer to inflammatory involvement of the intervertebral discs by spondyloarthritis. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1375. 24. D. Disruption of the spinolamellar line. The atlantoaxial interval is defined as the distance between the anterior aspect of the dens and the posterior aspect. Discitis. 24. A 4-year-old boy falls off his bike and complains of neck pain. Which of the following features is worrying for a serious injury on plain cervical X-rays? A. Atlantoaxial distance, 5 mm. B. Displacement of 6 mm of the lateral masses relative to the dens. C. Absence of lordosis. D. Disruption of the spinolamellar line. E. Anterior subluxation of C2 on C3. Aspect of the anterior ring of the atlas. This distance should be 5 mm or less. Pseudospread of the atlas on the axis, pseudo-Jefferson fracture, can be seen on anterior open-mouth radiographs. Up to 6 mm of displacement of the lateral masses relative to the dens is common in patients up to 4 years old, and may be seen in patients up to 7 years old. On extension radiographs, overriding of the anterior arch of the atlas onto the odontoid process can be seen in 20% of healthy children. In children, the C2-3 space and to a lesser extent, the C3-4 space have a normal physiologic displacement. The absence of lordosis, although potentially pathologic in an adult, can be seen in children up to 16 years of age when the neck is in a neutral position. In children, the flexion maneuver can increase the distance between the tips of the C1 and C2 spinous processes. Normal posterior intraspinous distance is a good indicator of ligamentous integrity and should not be more than 1.5 times greater than the intraspinous distance 1 level, either above or below the level in question. Anterior wedging of up to 3 mm of the vertebral bodies should not be confused with compression fracture. Such wedging can be profound at the C3 level. Chapter 4. Test Paper 2, Answers. 90. A prevertebral space of less than 6 mm at the level of C3 is considered normal in children. In pediatric patients, widening of the prevertebral soft tissues can be a normal finding that is related to expiration. Expiration. Disruption of the spinolamellar line is a sign of injury. C3. C3. 25. A 77-year-old man is brought into A&E with progressive increase in back pain. There is a history of known moderately large aortic aneurysm in the notes. A contrast CT is organized because the patient is hemodynamically stable. CT does not show any evidence of a ruptured aneurysm. All of the following are findings of pending rupture, except A, drape sign B, tangential calcium sign C, focal discontinuous intimal calcification D, retroperitoneal hematoma E, high attenuation. Injury. Lustrine ES, ETAL pediatric cervical spine, normal anatomy, attenuation crescent. Chapter 3. Variance and trauma. Radiographics. 2003, 23, 353960. 25, D. Retroperitoneal hematoma. A retroperitoneal hematoma adjacent to an abdominal aortic aneurysm is the most common imaging finding of abdominal aortic aneurysm rupture. The most common finding predictive of rupture is increase in aneurysm size, and thus it is the most common indicator for elective surgical management. Decreasing thrombus-lumen ratio is also predictive of increasing aneurysm size. The rest include drape sign, tangential calcium sign, focal discontinuous intimal calcification, and high attenuation crescent. High attenuation crescent represents an internal dissection of blood into either the peripheral thrombus or the aneurysm wall. It is one of the earliest and most specific imaging manifestations of the rupture process. Raketa D. Spectrum of CT findings in rupture and impending rupture of abdominal aortic aneurysms. Radiographics. 2007, 27, 2497507. Sing A. Emergency radiology, imaging of acute pathologies. Imaging of acute aortic conditions. New York, Springer Science and Business Media, 2013. 26, C. Hepatic 65. 26. A 56-year-old man with a history of PSC has an orthotopic liver transplant. He becomes unwell with a fever and acutely deranged LFTs on day 4 postoperative. An ultrasound is subsequently performed. What is the likely cause of his symptoms? A. Hepatic vein thrombosis B, portal vein thrombosis C, hepatic artery thrombosis D, CBD ligation and cholangitis E, gangrenous cholecystitis with perforation. Artery thrombosis in the early postoperative period, 72 hours after transplantation, increased hepatic artery resistance, resistive index of greater than 0.8, is a frequent finding, but resistance ordinarily returns to a normal level within a few days. Increased hepatic artery resistance is associated with older donor age and a prolonged period of ischemia. The estimated incidence of hepatic artery thrombosis among liver transplant recipients is 4%, 12% in adults and 42% in children. This is one of the most feared complications, as it may lead to fulminant hepatic necrosis. In addition, in liver grafts, biliary ducts are supplied exclusively by small branches of the hepatic artery, therefore, arterial thrombosis may lead to biliary ischemia and necrosis. Prompt diagnosis of hepatic artery thrombosis is extremely important because early intervention, with thrombectomy, hepatic artery reconstruction or both, may allow graft salvage. However, most patients ultimately require retransplantation. Even after retransplantation, the mortality rate approaches 30%. Risk factors for Hepatic artery thrombosis include a significant difference in hepatic artery caliber between the donor and the recipient, an interpositional conduit for the anastomosis, a previous stenotic lesion of the celiac axis, excessive duration of cold ischemia time, ABO blood type incompatibility, cytomegalovirus infection and acute rejection. KADU AHM, ETAL complications of liver transplantation. Perforation. Perforation. 27. A young woman with a palpable nodule in the breast undergoes a contrast-enhanced MRI breast for further evaluation. MRI demonstrates typical multiple non-enhancing internal septations. What is the diagnosis? A. Fibrocystic change B, abscess C, atypia D, fibroadenoma E, hydatid cyst. 28. A 20. Transplantation, multimodality imaging approach. Radiographics. 2007, 27:14-0117. 27. D. Fibroadenoma non-enhancing internal septations were initially described to have a high specificity in fibroadenoma diagnosis. However, this feature has recently been described in PTS and cancers and thus has little value when considered alone. Although morphological findings are important in lesion characterization, breast cancers may have a benign appearance. In particular, 30% of familial breast cancers revealed a mass showing benign morphological features with a round or oval shape, smooth margins and homogeneous internal enhancement. It should be considered that all enhancing masses in women with genetic risks are suitable for biopsy when there is a lack of typical cyst or fat necrosis findings. Millet I, ETAL pearls and pitfalls in breast MRI. BRJ Radiol. 2012, 85, 1011 197 207. Chapter 4. Test Paper 2, Answers. 91. 28, C, anterior. 21, year, old man presents with an acute knee injury following a violent tackle in a game of ice hockey. He is unable to weight bear. Plain film reveals a small elliptical bone fragment just adjacent to the lateral tibial plateau on the AP view. There is also an accompanying suprapatellar joint effusion. Based on the plain film findings and the mechanism of injury, what is the most commonly injured structure in this injury pattern? A. Medial meniscus. B. Lateral meniscus. C. Anterior cruciate ligament. D. Posterior cruciate ligament. E. Lateral cruciate ligament. This is a classic plain film appearance of a Seagon fracture. Seagon fracture is an avulsion fracture at the proximal, non-articular aspect of the lateral tibia. The presence of this fracture is strongly associated with injury to other knee structures like the medial meniscus. However, it is the anterior cruciate ligament that is most commonly injured, 75% 100%. Dannert W., Radiology Review Manual. Lateral collateral ligament. 29, a 36-year-old male patient with acute exacerbation of low back pain, shows an 8 × 5 mm intermediate signal fragment lying in the epidural space with signal characteristics closely matching the lower lumbar discs. However, no definite continuity can be established with any of the local discs. Inflammatory markers and white cell count are normal. The most likely cause for this appearance would be A. Disc extrusion. B. Disc protrusion. C. Meningioma. D. Schmoral node. E. Sequestrated disc. Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:90. 29. E. Sequestrated disc protrusion is present if the greatest distance between the edges of the disc material presenting outside the disc space is less than the distance between the edges of the base of that disc wider than tall. Extrusion is present when, in at least one plane, any one distance between the edges of the disc material beyond the disc space is greater than the distance between the edges of the base of the disc material, or when no continuity exists between the disc material beyond the disc space and that within the disc space taller than wide. The latter form of extrusion is best specified as sequestration if the displaced disc material has lost continuity completely with the parent disc. The term migration may be used to signify displacement of disc material away from the site of extrusion. Herniated discs in the craniocaudal, vertical, direction through a gap in the vertebral end plate are referred to as intravertebral herniations, Schmoral nodes. Nodes. Farden DF, ETAL lumbar disc nomenclature, version 2.0, recommendations of the combined disc. 30. A young boy undergoes an MCUG, which shows reflux of contrast into the right ureter and pelvicalicele system. The ureter and pelvicalicele system are not dilated. What grade is the reflux? A. 1B, 2C, 3D, 4E, 5. Task forces of the North American Spine Society, the American Society of Spine Radiology, and the American Society of Neuroradiology. Spine J, 2014, 14, 1125-2545. 30. B. 2 Grading of reflux. Grade I, reflux into distal ureters. Grade 2, reflux into collecting system, without calicele dilatation/blunting. Grade 3, all of the above, plus mild dilatation of the pelvis and calices. Grade 4, all of the above plus moderate dilatation of clubbing of calices. Grade V, all of the above plus severe tortuosity of the ureter. Prognosis. Grades I3 VUR resolve with maturation of the uretrovesical junction. Grades 4 and V require surgery to avoid renal scarring, renal impairment and/or hypertension. 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 Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. 31. A.